Well, thank you so much, Dr. Hatem, for taking all the time. So it's an honor to be here today, and would like to thank the IFRI again for having us on this beautiful day. And we have a full house here, mashallah. And this session will be about the recurrent pregnancy loss, the latest clinical perspective. Of course, I won't be coming today to educate you about recurrent pregnancy loss management. And for the sake of time, I think we need to move rapidly. So these are the main sources of guidelines that you would look for when you're trying to find evidence-based medicine to manage your cases of recurrent miscarriages or recurrent pregnancy loss, according to which nomenclature you're gonna follow: ISHRI, SRM, and RCOG. The latest are the ISHRI and RCOG. There had been recent updates. I just remind you about the main causes of RPL, and about half of cases will remain of unknown etiology. You will never know the reason why these patients are miscarrying. But the known causes are, of course, as you all know, endocrine factors, and autoimmune constitute the biggest proportion, followed by anatomical factors and genetics and infections. Genetic causes are, and briefly, I'll just go through rapidly the guidelines for parental karyotyping. The recommendations are conditional whether to investigate parents who have recurrent miscarriages or not, because it's all mostly for diagnostic purposes and counseling. But there is no evidence that if you're gonna do anything for this patient, PGTA has limited role in those patients, no clear benefits actually. And this has been repeated in the RCOG guidelines. The main difference that they recommend to do that for the cytogenetics for the recurrent pregnancy loss products of conception first, but if they're not available, you can test the parents for if there are hidden translocation or something. So the unresolved questions for these patients, will they benefit from PGTA or not? And they are emphasizing about the need to do a randomized clinical trial to test if patient with unexplained recurrent pregnancy loss will benefit from PGTA or not. Anatomical factors, there is a consensus about the value of 3D transvaginal ultrasound as a tool to screen those patients with recurrent miscarriages. So you must investigate those patients, preferably by 3D TVS. If it's not available, you can use MRI, and if not, you can use other modalities, but the 3D is the most preferable one. This has been emphasized in the RCOG, and there is unresolved questions whether to do resection for uterine septum or not. And only one small RCT showed no benefit of using hysteroscopic septum resection to reduce the rate of pregnancy loss in a patient with the recurrent miscarriages. And there is a lack of evidence actually to guide the management of acquired uterine anomalies like fibroids or intrauterine adhesions associated with the recurrent miscarriages, which is quite astonishing, as many of the gynecologists I know, if they found something distorting the cavity acquired, they will proceed directly, but we found that there is a lack of evidence at that point. Endocrinological factor, women with recurrent miscarriages should be offered thyroid function testing, and but patients who are euthyroid with TPO positive antibodies should not be routinely recommended to have thyroxine. Patients with subclinical hypothyroidism, moderate, they may be considered to have euthyroid treatment, but patients who are mild, they are not routinely recommended to have their TPO testing. And we're gonna move quickly. The progesterone treatment. Progesterone treatment should be considered in women with recurrent miscarriages who present with bleeding in early pregnancy. One of the doses, recommended doses, is 400 milligram micronized vaginal progesterone twice daily at the time of bleeding until 16 weeks of gestation. Unresolved issues are the cutoff level for TSH for subclinical hypothyroidism. Euthyroid patients with TPO, there is a clear link with recurrent miscarriages, but what to do for those patients? Luteal phase defects testing and the value has no, does this testing has any value? Acquired thrombophilia, the evidence is quite strong that women are recommended to screen for antiphospholipid antibody. And if find positive twice, 12 weeks apart, then they should receive the treatment in the form of low-dose aspirin and low molecular weight or unfractionated heparin. In hereditary thrombophilia, the HRE recommends against the screening of hereditary thrombophilia outside the context of research, so it's only research-based. The RCOG guidelines recommends doing also in research, but for a limited group of patients who had second trimester miscarriage, and only for part of the inherited thrombophilia, the factor V Leiden, the prothrombin gene mutation, protein S. These are the ones that may be proved in the future to have a significant role, but still in the context of research for now. As for now, there is no evidence that any treatment will modify the outcome of those patients. Other immunological factors, there is a consensus about the screening should not be screened for in patients with recurrent miscarriages. Infections should not be routinely offered. There is some evidence that patients who have recurrent miscarriage and have evidence of untreated chronic endometritis have a lower pregnancy rate than patients who had no endometritis or treated endometritis. However, well-designed prospective RCTs are lacking to find a conclusive answer for this question. What about the male factor? This has been also debatable between the gynecologist and andrologist. So andrologists are for DNA fragmentation testing, gynecologists some with, some against. The RCOG says there is a link between DNA fragmentation, there's a probable link. There might be explanation, but there is no evidence that any treatment you give to the patient will add any benefit. Also, the ISHRI guideline says that the DNA fragmentation testing just for diagnostic purposes. There is a link of sperm DNA damage and RPL, yes. Contributing factor, yes. But will treatment change the outcome? The answer is no till now. Unexplained RPL, they talked about the endometrial scratching. It is not recommended to do endometrial scratching for patients who have unexplained recurrent miscarriages. Lifestyle modification and biological factors, there's a big list of some factors that are contributing to the recurrent miscarriage, like the paternal and maternal age. These are not modifiable. Number of previous miscarriages, the black ethnicity, the smoking. Now we come to the modifiable factors like smoking, alcohol consumption, caffeine consumption, and BMI. So they recommended that patients who have recurrent miscarriages should be advised to have an ideal weight and stop alcohol consumption, stop smoking, and reduce their caffeine consumption to less than 200 milligrams per day. This is a category D recommendation. So now we come to some of the challenging cases. We have less than 10 minutes. So the first case, I would start with Professor Yaqub. We have a 32-year-old patient, Professor Yaqub, with a history of 4 previous pregnancy losses in the first trimester. She is planning to get pregnant again. You revised her lupus anticoagulant and anticardiolipin antibody and were found to be normal. Thyroid function test normal. Hemoglobin A1C and 3D transvaginal ultrasound are normal. What other investigations will you do for this patient? You have a list here. Anti-beta-2-glycoprotein 1. Will you proceed to do this investigation or not? CD markers, DNA fragmentation testing, parental karyotype, all of the above, none of above. You choose combination of these?
I think it's clear that the patient has recurrent pregnancy loss or recurrent miscarriage, judging by the number and by the confirmation that it is in the first trimester. The 3 essential investigations in any guidelines are the antiphospholipid antibodies and the structural integrity of the cavity of the uterus to rule out any anomaly or anything that mechanically contributing to the miscarriage. And the third is parental karyotyping. For economical reason in the UK, they don't advocate parental karyotyping. They say, please, when you have a miscarriage, send the product of conception, then we can know whether it is abnormal or normal. But for individual reason, parental karyotyping would be a good investment because it will give you an explanation. If either partner have chromosomal rearrangement, A, it explains the miscarriage, B, it opens the window for having treatment where you can choose the embryo that does not have this chromosomal arrangement. Anything else, definitely I will not touch CD16 or CD Barrani, neither. And then for what else? DNA fragmentation, again, it is insult to injury. It is adding insult to injury. and it's insult to intelligence. A sperm that fertilized the egg, that created an embryo, that was alive and had a miscarriage can never be attributed to sperm DNA fragmentation. And we should move away from that. That is where I stand. But I will not do any of the other investigation. Even with the general investigation, I don't see where is the role of HbA1c. I don't do it routinely for recurrent miscarriage. And what else did you do extra? Nothing. Okay, that's all.
Any other panel members have a comment?
بروفيسور يعقوب sometimes ما بتيجي عندنا some of the cases اللي هي early fetal demise after 12 weeks for the first time.
After 12 weeks is slightly different.
For the
slightly
first
different. Yeah.
for the first time.
Yeah.
For the first time. Sometimes from 8, 10 or 12.
That's first trimester. Yeah.
I'm going to follow the guidelines and wait for the second pregnancy, which is the 8 weeks. She is 8 weeks and missed abortion occurs. I'm going to start the workup or wait for the second pregnancy.
I would not start the workup from first pregnancy because miscarriage is rather common. It happens in 1/6 of the pregnancies and random. If you walk in the street and survey women, you will find 1 in 2 had the experience of a miscarriage. So it is not advisable to initiate complex and expensive investigation for one miscarriage.
The second controversial issue, non-visualized pregnancy loss.
Yes, that's
Recurrent-
biochemical.
Recurrent
Yeah.
biochemical,
Yeah.
yes. What do you-
Biochemical
after
is one
three-
of the most
after
frustrating
three-
diagnosis, and unfortunately, it does not have the same even biological explanation as clinical miscarriage.
Yes.
It happens in 20% of pregnancies, whether it is naturally conceived or whether it is assisted conception. But the prognosis after biochemical pregnancy loss is much better than having a clinical pregnancy loss. So you reassure the patient and hope. If anything to add is perhaps to give her a bit of additional progesterone because it's innocent, it's not expensive, and it might be coincidentally or causatively have something to help. Yes.
Actually, I want to highlight that the ISHRI guideline emphasized that there is no difference in the terms of outcome of the investigations that be done for patients who have clinical pregnancy loss or biochemical, yes. And to the second question, 25-year-old patient with a history of 2 previous pregnancy losses in the first trimester. She is currently pregnant in her 6th week of gestation. A week ago, she has been prescribed a daily low molecular weight heparin and low-dose aspirin by another physician. You revised her antibodies that were done properly, and you found that her antibodies for antiphospholipid antibodies were normal. So what will you do? So I want to survey the whole now, a show of hands. Who will continue the same regimen for this patient? Okay. Who will add progesterone? Okay. Who will add calcium? Okay. Who will give aspirin alone? Okay. Who will stop all treatment? Who will add tacrolimus? Okay, that's good. Who will have a combination of adding progesterone and calcium? Who will have adding progesterone and giving aspirin? Okay. So now I move to the panel. Dr. Hazim, what do you think about this case?
Two losses and that?
Yes. 2 losses. She came to you pregnant. Someone prescribed her low molecular weight heparin and low-dose aspirin. But her antibodies are normal. And they were properly done.
She's doing LA only and anticoagulation?
All normal. Yes. LAC and the ACL. No.
I may do additional investigation for thrombophilia before continuation of heparin.
Okay, so
Yes,
what will you do?
Stop.
She's taking the medication.
Stop.
She's already taking it. That's number 1. Number 2, hereditary thrombophilia is never indicated in first trimester.
No,
Only the acquired.
acquired, yes.
Yeah, but she already having the stuff.
I may do
think the challenge-
anti-beta glycoprotein 2. If it's negative, we stop the treatment.
Anti beta 2 glycoprotein.
I think this question is kind of a trap.
Yes.
It's a local trap, because if it is in London, I will say you are taking stuff that it's not justified. But here, if you tell her to stop heparin and she miscarry, you will have yourself shot in the following day.
Yes.
So you might as well. Most people are taking empirical heparin, just pretend you don't know and ask her to continue with what she's taking.
لا حضرتك if you could ask for a further investigation or stop? No,
there's
nothing.
She's already pregnant. You just pray. That's all.
Okay, so we move to the next case. 29-year-old lady, para 0+3. She all her miscarriages first trimester, diagnosed only by positive pregnancy test with no ultrasonographic or histological confirmation. So, what investigation plan will you request for this patient, Dr. Muhammad Sabri? Yes.
All her miscarriage in first trimester diagnosed only by positive pregnancy test. There's no ultrasound.
Will you treat her as a routine RPL patient, or we should be considered as shouldn't be considered as a RPL and should receive otherwise standard care? Only karyotype for the couple, only APA testing. This patient may benefit from oral prednisolone given her early in the next pregnancy. What will you do for this patient? This is another trap.
Yes. لا تراب يعني.
We discussed that the biochemical, because these are biochemical.
Yes.
They don't
Yes.
follow the same pathway.
We shouldn't same the same pathway.
Okay.
Yeah.
So you treat
Receive
her
the
as
same care as recurrent pregnancy loss. Number one.
treat her number one. Okay. So according to the ESHR guideline, they should receive the same management as patients who have clinical pregnancy loss. And I want to also highlight that we had a big retrospective study I was part of in UBC, comparing the three groups of patients with pure non-visualized pregnancy loss and patient with visualized pregnancy loss only, and patient who had a combination of both. And there was almost no difference in the outcome in terms of the live birth and cumulative birth rate for this patient in the future. They had differences in some prognostic factors, points like the risk of ectopic pregnancy was higher in the non-visualized pregnancy loss, and they are less likely to have intrauterine adhesions as compared to other groups. But otherwise, in terms of future pregnancy, they were almost the same. The fourth question is the 35-year-old patient, para 0+2, and her last abortion was 4 months ago. She's currently using a barrier method as a contraception. She came to you presented by abnormal vaginal discharge, and ultrasound examination showed intrauterine rim of fluid. You suspected the diagnosis of endometritis. How would you proceed, Dr. Muhammad Yahya?
بصراحة لو أنا شاكك في اندومترايتس مش هعمل حاجة غير إن أنا أدي لها امبيريكال انتيبيوتكس.
Empirical treatment.
مش ه I'll not go forward for hysteroscopy and biopsy و CD 138. It's expensive and the management with the antibiotic is a little cheap. وأعتقد إن هو 10 أيام من الدوكسيسايكلين هيبقى sufficient.
Okay. Any panel members have opposing or different point of view?
Same response.
Empirical treatment.
Yes.
Okay.
في الهستروسكوبي مش هقدر اشخص مظبوط يعني.
Okay.
هضطر ان انا اعمل سي دي 138 هو بيكلف حوالي 1000 جنيه.
Yeah.
والتريتمنت مش هيكلف 100 جنيه.
So the fifth question is kind of 48-year-old patient, para 0+40, no living, severe semen abnormalities, normal karyotype, and have normal immunological testing, no anatomical abnormalities, normal thrombophilia screen, and failed XC. She left the reproductive world with no children. Could you have helped her before?
دكتور عمرو، الحقيقة أنا نزلت الحالة دي هي فعلا كانت سيفير اوليجو اسين و sometimes occasional immobility sperm، بس بيحصل spontaneous documented pregnancy by beta SCG and ultrasound. Along a number of from 5 to 10 years she aborted this number of abortions. فانا نفتح بس الفلور، هل احنا اجرمنا في حق هذه الحاله وكان ممكن تعمل لها حاجه ولا لا؟ فلو في حد من الفلور يقول هيز اوبين، وبعد كده نسمع راي استاذنا الدكتور يعقوب فيها.
Any comments from the floor? دكتور علام، بروفيسور علام.
كانت استفادة يعني قبل سن ال40 يعني على الاقل كنت عملت لها VGTA بحيث اشوف لو كان عندها aneuploid embryos او whatever gene problems I could help her. شكرا.
Any other opinions?
هل هي حصلت على اي جنين عدى الشهر الثالث قبل كده؟
First trimester, all first trimester.
All first trimester.
I must say I have never heard of patient having 40 miscarriages. Never. I know. Yeah.
دكتور عمرو ليه بس
دكتور يعقوب
اقولها الادوبشن والتبني في القصص اللي زي كده. انا I don't know exact way ان احنا ننصح بيه العيانين لو كان دوت available. لان انا
I don't think it is allowed. I don't think from religious or societal perspective adoption.
تبني.
ما هو ده تبني adoption.
ايوه طب فده واي religiously لا
I don't know. ادعوهم لآبائهم.
ايوه بس هتبقى معاها هتكفله.
تكفله حاجه غير حاجه اسمه fostering not adoption.
اوكي مش هتبقى على اسمهم بس هي
that is even very charitable. Even in the United Kingdom sometimes a patient reaches a dead end, you tell her you can go and have egg donation in Spain, we can refer you. He said why? The world is full of children that need to be cared for, and you will go and do fostering or adoption. Yeah.
تنصح في الحاله دي هل ممكن تستفاد برغم ان هي كان عن سيفير اولجو اسن وساعات اوكيجن اموتار سبيرم، هل ممكن كانت تستفيد من سيرجيكال سبيرم اكستراكشن وتعمل لها اكستي بالمنظر ده؟ هي خلاص الست lost يعني leave the world without children.
That's all history now. She got 48.
Yes.
But also, if she had karyotyping and done by expert centers, some chromosomal abnormalities are incompatible with viable pregnancy. That could have given her at least explanation.
For the husband, you mean?
Yeah, no, for both of them. We don't know which one. And some abnormalities involving ring chromosome or involving certain chromosomal abnormality, we have come across this, where the cytogeneticists say don't try.
Some of the genetic factors may be implicated, genetics not chromosomal.
No chromosomal. Most of, we can't exclude the other either.
Well, we came to the هم قفلوا السكرين.
لا فضل question واحد بس. One question only.
There is one question.
One slide only. One slide only.
بس خليك دكتور محمد.
يعني advice انما هقول comment. We have to say sometimes we don't know and we stop. يعني ما
Nobody will stop her trying.
This case is spontaneous. This case was spontaneous abortions, not trial. Spontaneous abortions. Spontaneous abortions.
So if she tried, that's fine. But we must always admit that we don't know.
Yes.
When we don't know.
So we have not committed any crime in her right.
No.
Okay. This comment is related to the last case. So this case has had 30 years old and she had 14 previous miscarriages, all occurring between 12 and 20 weeks. And she is antiphospholipid antibody positive. Otherwise, she's normal. And she received the maximum treatment. But she took out of label treatment that are not evidence-based. And she managed to get pregnant and have complete her pregnancy till the end and had a male and female this way, although it's not evidence-based. So now we are cutting between like two parts, like whether to follow the guidelines and stick, otherwise this patient wouldn't have had her kids probably according to her belief, and some people believe this, or we should have stick to the guidelines and she would have reached this outcome regardless she took that treatment or not.
حتى عمرو هعلق برضو على الحاله دي. كان الابورشن كلهم من 12 ل 20 وكلهم typically missed. She's a pharmacist and finally after losing hope with us she started net treatment, empiric net treatment in the form of steroids and immunological therapy.
I didn't.
I was discussing with
Yes.
with Professor Yaqub. Is there a chance that we could try more to do more studies in these abortions more than 10? I'm not talking the abortions 3 or 4, more than 10 with the presence of an embryo and loss pulsation?
No, I think it is important to appreciate again that we don't know everything. That's number one.
Yes.
Number two, circumstantially, it's possible that the treatment that she had may have helped, but materially, it may have nothing to do. And
Yes.
by chance alone, she could have had the same outcome, because there will always be something outlier in terms of treatment. It does not mean that we should adopt this treatment without evidence.
Okay. So at the end of the session, I want to thank all the panel members for this wonderful chance to share their knowledge with the audience, and I want to thank the audience for staying for this. We are beyond time by more than 7 minutes. Thank
حد
you
يسأل
for the
سؤال.
effort for accommodating
طبعا حد
us.
يسأل السؤال
معلش قدام سؤالين دكتور احمد. هاي.
الحالات اللي فيها ريبيتد بريجنانس لوس، انا يعني مع بعض الحالات ماي اكسبيرينس، يعني كل الحالات كنت نفسي اسال في الحاله اللي كان فيها ريبيتد بريجنانس لوس 4 تايم او 12 تايمز وات اباوت ذا بودي ماس اندكس. يعني كنت الحالات اللي انا بشوفها وبيحصل معاها الحالات اللي زي كده ومعمول لها يعني الجايد لاينز، كنت الاقي فيها الحالات اللي فيها البودي ماس اندكس هاي مور ذان 30 وكنا نعملها كوركشن، كان البروجنوز بتاعها بيبقى كويس خالص. فنفسي كنا يعني لازم نعلق
تلاقي حضرتك فيها، معلش انا بس مش سمعتش.
وات اباوت ذا بودي ماس اندكس، هل
بودي ماس اندكس.
يس
هي دي كانت
حالات كتيره كانت تستفيد لما نعمل كوركشن
65 to 70 كيلوغرامز. هي الحاله اللي هي برازيل بلس 14.
نورمال بي ام اي.
يس نورمال بي ام اي. نورمال بي ام اي.
استاذي يا دكتور يعقوب، لان انا في حالات كتيره بتاجي للقاهره بتعمل اكسي وبتكون البودي ماس اندكس بتاعها مور ذان 35 وبلاقي والبروجنوز بتاعها فيري باد، بيكون الابورشن يعني مش عارف يعني انتوا.
No, no, there is increased risk of miscarriage with high BMI, but
Yes.
it can't explain that inordinate number of miscarriages.
Yes.
High and low.
Yeah.
High and low BMI. Yes.
شكرا.